Hi guys, good evening, good evening, good evening. Hi Rahul, good evening. Hi Sunil, good evening. Yeah, so continuing on the trauma series of BLS, so आज we'll be talking about the abdominal traumas. ठीक है? So today we'll be talking about abdominal trauma. One second, what's happening here? Okay. Right, guys. So today's topic will be about abdominal trauma. Today I'll give you a basic introduction of abdominal trauma, and then from thereafter we'll try to build as we move across. Okay. So let's begin the topic for today. So we're talking about abdominal trauma. Now, abdominal trauma is actually a very vast topic. As we continue to move on, you'll understand that we have to take a different approach in the abdominal trauma. We'll talk about a generalized approach, then we'll talk about organ specific injury approach, and then the protocols and the management. All that will continue to add as we go across the abdominal trauma. Now, a couple of important things as you look into the abdominal trauma is when you look at the specific injury in the abdomen, you need to know that what specific organ might get damaged in a particular phenomena, right? For example, if I say, what is the most common organ injury? Which is the most common organ injury in abdominal trauma? The most common organ injury in an abdominal trauma overall. I'm not saying whether you're talking about a blunt trauma abdomen or you're talking about a penetrating trauma abdomen. Currently, with respect to the combined consensus, the answer is going to be liver. So, overall, most common organ injury in the abdominal trauma is going to be liver. But if I become a little bit more specific and ask you what is the most common organ injury, what is the most common organ injury in blunt trauma abdomen? In the blunt trauma, then the answer here will change to spleen. So specifically, I'm asking the answer is going to be spleen if it is going to be blunt trauma abdomen, right? If I change the question and ask you what is the most common organ injury, what is the most common organ injury in penetrating trauma abdomen? In a penetrating trauma abdomen. Now, again, this is something you would basically use a logic to know that what organ might get injured. Now, in a penetrating trauma abdomen, let's say we'll take a hypothetical situation that this is a guy who is actually an assassin, okay, and this guy wants to kill a guy who he has taken the money to kill, right? So this is the guy we have given. This assassin has gotten money to kill this guy, and he is specialist in killing people by stabbing them in the abdomen, right? So he is specialist in killing the people by stabbing them in the abdomen, right? So this is the guy that he decides to kill, right? Now, when you, let's say he has a weapon in hand, let's say it's a knife or something, and he wants to stab this guy and he wants to kill it, what is the first thing that you're going to do? Now, majority of us are right-handed, right? So obviously you want the right hand to be there, which is going to be having an instrument, or I can say weapon, and the left hand is free. So the first thing you're going to do is, you don't want this guy to run away. So with the help of the left hand, I'm going to hold this guy so that this guy does not run away. So yeah, with the left hand, I'm holding the guy. Right hand, if I want to stab somebody so that the patient would die, or a person would die, I will try. I will not try to do like this, because if I try to look that this does not give me enough amount of force. It goes like this and springs back. I want it to go in, so I'll be using my shoulder and I'll try to go as deep as possible. I'm holding the person, I'm using my shoulder, and then I'm going to go like this, right? So because majority of us are right-handed, when you're targeting, you're holding the person with the left hand and you're angling towards the right upper abdomen. This is how the angle is going to be, right? If there's a person here, this stab or this instrument of stab the person is going to have let's say this is the instrument of stab the person is going to have. This is the instrument of stab the person is going to have. Now when it is going to move, it will move in this particular fashion, right? It will try to go in the right upper abdomen, right? Now in the right upper abdomen, which organ is there? Now he's trying to stab, he's holding it and he's going to stab it. Obviously the right upper abdomen, what do you have? You have liver, right? So that is why the most common organ injury, if you're looking at a penetrating trauma abdomen, if you're looking at a penetrating trauma abdomen, it is going to be liver. It is going to be liver, right? Now, let's say in a penetrating injuries, I can give you a gunshot also. So if I say what is the most common organ injury in a gunshot wound to the abdomen, in a gunshot wound to the abdomen. Now, if you're shooting, so for a gun, no, you don't need to do all these angles and all. Take the gun, point it in this, in the abdomen, and shoot it. Now, it's a normal tendency that you want to shoot dead in the center. The maximum is in this area. So, right in the center of the abdomen, you have the small bowel. So, hence, in a gunshot wound, it is usually the small intestine which is going to be affected. If not, if it goes lateral, it will go into colon. It can go into other organs like liver as well, but usually it is going to be small intestine followed by colon, right? Let's say patient is traveling by a car, right, and is putting up a seat belt. The seat belt is going to go from the right shoulder to the left one, right? So it is going opposite to that of the root of the mesentery. So this is the seat belt that you have. So when you look at the patient, if the patient is driving the car, right? So this is the patient who is driving the car, let's say. This is the patient who is driving the car. You will see the orientation of the seat belt will be from right to left. This is how the seat belt will buckle, right? You see the orientation of our mesentery is going to be towards the opposite direction. That means from the left of your second, third lumbar vertebra to the right iliac fossa. So seat belt goes from right to left, whereas your mesenteric root goes from left to right, right? So they're in two opposite directions. So what is going to happen? Now, once the patient hits a car, the body is going to go one way, the seat belt is going to pull on another way. So there is a traction and a counter traction that occurs on the abdomen, and the mesenteric root gives away. That is like, it's like the seat belt is going to pull the patient this side. So the car goes this side, the body goes this side, right? So seat belt tries to pull the body, but it is pulling perpendicular to the root of the mesentery. Hence, the mesenteric root gives away. So if they say what is the most common organ injury, the most common organ injury in seat belt. In seat belt, it is going to be the mesenteric tear. This is going to be the mesenteric tear, right? Now, apart from that, if they say what is the most common organ injury in a rapid decelerating injury in the abdomen, the most common organ injury in rapid deceleration. In a rapid deceleration of the abdomen, it is going to be splenic flexure. It is going to be that of splenic flexure, right? If they ask you what is the overall most common organ injury in children, most common organ injury in children overall, I'm not saying blunt trauma or penetrating. In children, the answer is going to be spleen. In children, it is going to be spleen, which is more likely to be affected. Okay? So these are the various important points when it comes down to the abdominal traumas, right? Now, now what happens is any patient who lands up with abdominal trauma, I can segregate the abdominal trauma into two categories: the blunt trauma abdomen and the penetrating trauma abdomen, right? In general, so talk about the general protocols in the abdominal injuries. So imagine if you have a patient with blunt trauma abdomen. Now, if the patient is going to present to us with blunt trauma abdomen, if the patient is going to present as blunt trauma abdomen, how would you react or how would you look across this patient? Any patient who lands up in your casualty with the blunt trauma abdomen, irrespective of the status, the first thing I would like to do is what we call it as FAST. Now, FAST stands for focused assessment. It is a focused assessment with sonography. Focused assessment with sonography in trauma is what we call it as FAST, right? So take an ultrasound, we'll quickly look into the abdomen to see is there any problem is present or not, right? Now, when you're doing the FAST, that is a focused assessment with sonography in trauma, when I give you an ultrasound probe, what are the sites that you're going to look into? So the FAST says that you have to, jump right into it and then perform a 4P evaluation. You have to do a 4P evaluation. What is the 4P evaluation? I give you an ultrasound probe. The first thing you are going to look across is going to be in the perihepatic space. The second thing you'll be looking into the pericardial space. The third is going to be perisplenic. And the last you'll be looking into your pelvic space. So when I give you an ultrasound, these are the 4 sites. You take the ultrasound and jump right at it. So what are the sites you're going to look into it, right? The first one is going to be perihepatic. It is the perihepatic. Then you have perisplenic. It is a perihepatic, perisplenic. Sorry, this is a pericardial. This is the pericardial. This is your pericardial. This is your perisplenic. And this happens to be pelvic. Right? So the pericardial, the perihepatic, the perisplenic, and the pelvic are the sites where you would like to assess, right? The problem with the focused assessment with sonography and trauma is if the collection is less than 100 cc, it is very difficult for us to pick up an ultrasound. So that is why we say how much should be the minimum fluid requirement. Say minimum amount of collection. Minimum amount of collection required. Minimum amount of collection required for FAST to be positive. The minimum amount of collection required for FAST to be positive, it is going to be 100 cc. Less than 100 cc, no, it will not give you a good sensitivity. So more than 100 cc collection, it can immediately or eventually pick it up, right? It can eventually or immediately going to pick it up, right? Now, right. There is an extension to the FAST now because you also want to rule out the traumatic injuries which can cause diaphragmatic injuries, which can result in pneumothorax or it can cause herniation, all that to rule out. So the new addition to the FAST is what we call it as an EFAST. EFAST is a concept of extended fast. EFAST is a concept of extended fast. In an extended fast, so rather than just limiting ourselves to abdomen, we'll quickly do a thoracic assessment also. So we say it is a 6-site assessment. So look at this is the thoraco-abdominal status. So let's say this is a representation of the patient that we have. And it goes across like this. Right. Now, let's say this happens to be suprasternal notch. This is the sternum. This is the Ziffy sternum. And let's say this is the diaphragmatic attachment that you have. Right. Now, just for the sake of understanding, I'm saying this is the pelvis. This is the pelvis. This is the umbilicus. Right. So we divide the entire context into 4 different categories that you have. It is the right thorax. We do a right thorax. This is your left thorax, or I can say left hemithorax. This happens to be your right hemithorax. This happens to be your right hemithorax. Abdomen will be categorizing them into four different status. Going to right upper abdomen. You have the right lower abdomen, left upper abdomen, and the left lower abdomen. If you do an assessment of all the 6 sites, this is what we call it as an extended fast, right? So in an extended fast, I would be able to evaluate for pneumothorax as well. So what are the ultrasound findings to know whether the patient is having a pneumothorax or not? So if the patient is having a pneumothorax, on an ultrasound finding, what are you going to see? The first one, you will see there is an absent seashore sign. Now, this absent seashore sign basically means when you put an ultrasound probe in you and me, as you see, with inspiration and expiration, the pleura is going to move towards the chest wall and away from the chest wall, right? So that keeps on happening with every inspiration and expiration. So when you put an ultrasound probe, you feel as if your visual pleura is coming and going. So that movement closer to the chest wall and moving away looks like a wave. So hence it is called as a seashore sign, like the waves are coming at the end of the seashore. When a patient develops a pneumothorax, the air compresses the thorax, lung per se. In that context, during inspiration and expiration, the lung cannot have this movement. If the lung is not able to move, the pleura doesn't move. If the pleura doesn't move, you will not have this movement like a wave in an ultrasound. If there is no waves absent, that means the lung is not moving. Why is the lung not moving? The air that is accumulated inside the thorax is compressing the lungs and not allowing the lungs to expand, and that tells you there is pneumothorax. The absence seashore sign, or there is presence of this barcode sign. This presence of this barcode sign, or also called as the stratosphere sign, or also referred to as the stratosphere sign, right? Now let's say you have a patient who is fast negative but is still suspecting there's some amount of abdominal injury. What can you do? Nowadays we don't do it much, but there used to be a concept which is called as DPL. Now what is DPL stands for? DPL stands for diagnostic peritoneal lavage. DPL stands for diagnostic peritoneal lavage, right? Now what is this diagnostic peritoneal lavage? Now the diagnostic peritoneal lavage is, normally what we do is, let's say this is the representation of the abdomen. See, now fast has purely replaced DPL. We don't need to do DPL, but sometimes even in modern days, if the fast is inconclusive, you can resort back to that of the diagnostic peritoneal lavage, right? So this is the umbilicus that you have, right? In a diagnostic peritoneal lavage, infra-umbilical, I'll give a small incision, like a stab incision, and I will insert a cannula or a tubing through this, right? Now this cannula or a tube that you have inserted through the stab wound into the abdomen will actually be connected to a syringe. It will be connected to a syringe. This will actually be connected to a syringe, right? So normally we give a small stab 1 centimeter incision in the infraumbilical region. We will insert a tubing through that and then connect it to a catheter. I mean, you just insert a catheter inside and then connect it to a syringe, right? And then you will instill the fluid. Now before doing that, now what is step number 1? If I go stepwise, it is a 1 centimeter stab incision. A 1 centimeter stab incision in the infraumbilical region. In the infraumbilical region, there is this 1 centimeter. There's 1 centimeter stab incision in the infraumbilical region, right? Then you have to insert a catheter through the incision. Insert a catheter through the incision. So insert a catheter through the incision. Okay. And they're pointed towards the pelvis. Pointing towards the pelvis. Pointing towards the pelvis, right? So give a 1 centimeter stab incision in the infraumbilical region. Insert a catheter pointing towards, or you direct that catheter going towards the pelvis, right? Step number 3 is connect to a syringe. Connect to a syringe and aspirate. Connect to a syringe and aspirate, right? Now, you can have two things. As soon as you've connected this to a syringe and you aspirate, there'll be positive for aspirate and there'll be negative for aspirate. There'll be positive for aspirate. There'll be negative for aspirate. That means when you pull, you might see something, you might not see something, right? If it is positive for aspirate, now one of the most alarming thing is on an instantaneously, if you get more than 100 ml of blood, if you get more than 100 ml of blood as aspirate, on a start, if you get more than 100 ml of blood as aspirator, then you have to suspect intra-abdominal injury. Then you have to suspect the intra-abdominal injury. Then you have to suspect for intra-abdominal injury, right? On the other hand, if it is nothing, we call it as a dry tap. Again, dry tap does not rule out that there is no problem at all. So in order to conclude what does this dry tap really mean, you're going to instill saline, right? So normally we instill 100 to 200 ml of saline. We will instill saline and re-aspirate. Now this, whatever you have done, this is what we call it as effluent. So this is re-aspirate that you collect in a syringe is what we call it as effluent. This is what we call it as effluent, right? Now this effluent will be sent for analysis, right? Now on a lab analysis, if it has got more than 1 lakh of RBC, if there are more than 100,000 RBCs which are present in the effluent, if there are more than 500 WBCs, if there are more than 500 WBCs, if there is presence of fecal component, if there is presence of fecal component, if there is presence of bile, or if there is presence of purulent collection. If any one of the following is present. So when you do this effluent mechanism, you instill the saline, do a reaspiration. On the analysis, if any one of them is positive, if any one is present, suspect abdominal injury. If any one is present, if any one is positive, then you should suspect abdominal injury. You can suspect abdominal injury, right? So this was the older concepts that you have: diagnostic peritoneal lavage. Now the DPL is replaced. So right, it's not a very popular option. You can now quickly say that the diagnostic peritoneal lavage is replaced. It is replaced with FAST. The diagnostic peritoneal lavage is no longer considered to be a popular option. As you can see, it is quite invasive. So the non-invasive method, which is ultrasound, is reliably used. The only problem with the ultrasound, no, it is an operator dependent, right? If your radiologist is not skilled enough, he might miss the findings, but otherwise DPL is now replaced by standard fast. Okay, as simple as that. Clear? Now, coming back to our protocol, we said if the patient comes to you with blunt trauma abdomen, how are you going to deal with it, right? Any patient who lands with blunt trauma abdomen, any patient who lands with blunt trauma abdomen, the first thing we see or the first thing we do is as soon as the patient comes, I'm not worried about the component here. Blunt trauma abdomens, patient land up into the casualty, we will perform fast. Either you can say fast or you can see an E fast. Now, once you're done with the fast or an E fast, I can have two possible outcomes from this scenario. Either I'm going to have a fast positive or a fast negative status. Either I'm going to have a fast positive or fast negative. That is, what is a fast positive, what is fast negative is. Fast positive is on ultrasound, you can see there is significant fluid collection or some amount of collection that is going to be present. Now, if it is fast positive, you will assess the patient in this context where the patient is hemodynamically stable or whether the patient is hemodynamically unstable. Now, if the patient is hemodynamically unstable, if the patient is hemodynamically unstable, you do not have any or again a much option to look for. You'll take the patient immediately for exploratory. You take the patient immediately for exploratory laparotomy. You take the patient immediately for exploratory laparotomy. On the other hand, if the patient is absolutely stable, if the patient is absolutely stable. Now, if the patient is stable and it is fast positive, I need to know that which organ has been injured. Now, in order to know which organ has been injured, I will take the patient for CCT abdomen. Will do or take the patient for CCT abdomen. Now, CCT abdomen, in fact, is the investigational choice for the assessment of blunt trauma abdomen in a hemodynamically stable patient. In a hemodynamically stable patient, right? Now, what you're looking on a CCT abdomen is there any evidence of hollow viscous perforation? The first thing you will look is going to be a status of hollow viscous perforation, right? You can have two objectives here. Either the hollow viscous perforation is present or the hollow viscous perforation is going to be absent, right? Either the hollow viscous perforation is present or absent. If it is present, again, no point in arguing. Take the patient immediately for exploratory laparotomy. You take the patient immediately for exploratory laparotomy. Okay? So you will assess the patient for hollow viscous perforation on a CT. If it is present, take the patient for exploratory laparotomy. If there is no evidence of hollow viscous perforation, you would look for solid organ injury. So when I say when I'm looking for a solid organ injury, in a solid organ injury, I am looking for injury to the liver. I'm looking for injury to the spleen. I'm looking for injury to the kidneys and injury to the pancreas. So there are the four major abdominal organs that I'm going to look across when you're going to assess. So solid organ injuries, you look for injury to the liver, injury to the spleen, kidneys, as well as pancreas, right? Now, when you look at the solid organ injury, I can have two objectives here on a CT. Either the solid organ injury is present or the solid organ injury is absent. So I can have two possible scenarios: presence of solid organ injury, absence of solid organ injury. Now, if it is presence of solid organ injury, I would look on a contrast imaging that is there any pseudo aneurysm. If there's presence of a solid organ injury, you would look for presence of pseudo aneurysm. If there is any pseudo aneurysm or if there is any contrast blush. Now, what is the concept of a contrast blush is? That means the contrast is leaking out. Now, as it leaks out, it creates a cloud. It creates a leak cloud, and that cloud of leak is what we call it as a contrast blush. So, either if there is evidence of pseudo aneurysm or if there is presence of contrast blush, you have to intervene it immediately. So, you will see whether any of these two is present or absent. Okay? Either there is presence of contrast blush or pseudoaneurysm, or there is no evidence of this. If it is presence of contrast blush, you will try to seal it with the intervention only, and that is your angioembolization. It is the angioembolization of the vessel with contrast blush. With contrast blush. If there is no pseudoaneurysm, if there is no contrast blush, then you would going to grade the injury. So here it is going to be a grade wise management. Here it is going to be a grade wise management, which we'll discuss in detail. Okay. So this is how you will address a patient with the blunt trauma abdomen. So whenever a patient lands up to you, this is how from start to end of our patient's assessment is going to be taken care. We'll start from the fast status, where we'll say stable, unstable. Unstable, go with exploratory laparotomy. Stable, do a CCT abdomen. Look for hollow viscous perforation. If there is no hollow viscous perforation, look for solid organ injury. In a solid organ injury, you have to look for any pseudoaneurysm or contrast blush. If there's no pseudoaneurysm, no contrast blush, you can go with grade-wise management. If not, you have to go with angioembolization of the bleeding vessel. Right? Now, come back here. If there is no evidence of any solid organ injury, then you have to manage other injuries. Manage any other injury present. Manage any other injury that is available. Okay. So this is how you look for fast positive one. If it is fast negative, patient is blunt trauma abdomen, status with fast negative, again you will assess the same, whether the patient is stable or whether the patient is unstable. Right? If the patient is unstable, in an unstable patient, even if the fast is negative, in a blunt trauma abdomen, you will take the patient. So now this is quite tricky, that you need to understand that you did a patient comes with blunt trauma abdomen, right? You did a fast, the fast is negative, right? The patient is unstable. Blunt trauma abdomen, fast negative, but the patient is hemodynamically unstable. For any hemodynamic instability, even if the fast is positive or negative, this is an indication. So here ideally you should do a diagnostic laparoscopy and proceed. Okay? Technically talking, if the patient is unstable, you do a on-table diagnostic laparoscopy and proceed. So here it is going to be diagnostic laparoscopy. It is diagnostic laparoscopy and proceed. This is one option that we have, right? The option number 2 is to take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Now, if you look at the options in these two, the better option would be your exploratory laparotomy over a diagnostic laparoscopy, right? On the other hand, you did the fast is negative, the patient is hemodynamically stable. Here it is only observation. Here it is going to be observation. Here it is going to be observation. Right. So again, unstable patient, I can give you a consensus here. Fast is negative. How do you know patient is unstable? Either the patient is presented to you with peritonitis, either the patient is having peritonitis or the patient is in a state of shock. If any of these two are present, I will deem them as unstable. Okay? So these are the objective. Again, do not fall into the trap of diagnostic laparoscopy. This is now getting a popular option, But if they ask you what is the standard line of management in an unstable patient with fast negative, which features suggestive of peritonitis or shock, the answer is going to be exploratory laparotomy. If this is not being given or served to you, then you can go diagnostic laparoscopy. It is also getting popular. Okay? Chalo. So this is about your blunt trauma abdomen, right? So this is how you're going to manage your patients with blunt trauma abdomen, right? So can we go with penetrating trauma abdomen? So the next protocol that you should know is about penetrating trauma abdomen. Your penetrating trauma abdomen. So the protocol for the penetrating trauma abdomen, it is to see whether the patient, whoever is having a penetrating trauma abdomen, is it secondary to a gunshot wound or is it a stab wound, right? So the first thing you will assess that the patient that you're addressing, is it a gunshot wound? Is it a gunshot wound or is it a stab wound? Is it a gunshot wound or is it a stab wound? As simple as that, right? Is it a gunshot wound or is it a stab wound? Now, whichever patient lands up to you with gunshot wound, whether the patient is stable or unstable, whether the patient is stable or unstable, because all gunshot wounds are high velocity injuries, they're deep penetrating injuries, they are associated with multiple organ injuries. Even if the patient is stable or unstable, it does not matter to us. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy, right? Take the patient for exploratory laparotomy. Okay? On the other hand, when you have a patient who has presented to you with a stab wound, right? Any patient who lands up in the casualty with a stab wound, the first thing that you will assess is the status of the weapon of stab. It is the weapon of stab. That means if the patient is stabbed with a knife or with some, let's say an iron bar or some sword or anything, any sharp object, you will see that what is that status of the weapon. If your weapon of stab, is it in the body or not? So we will assess if the weapon of stab is in situ. That means it is still in the body. We have seen patients who have walked up to the casualty with the knife sticking into the abdomen. They have come like this, there's a knife sticking into their abdomen and they walked right into it. So we see weapon of stab, is it in situ or not? So weapon of stab, you'll see whether it is in situ or whether it is not in situ. Whether the weapon of stab, it is present inside the abdomen. Is it in situ or it is not in situ? Now, if the weapon of stab is in situ, if the weapon of stab is in situ, you will see whether the patient is hemodynamically stable or unstable. You'll see hemodynamically whether the patient is stable or unstable. Now, before I move on with the further protocol, anytime if a patient comes to you with the weapon of stab in situ, as a note point, remember, you should never remove the weapon. You should never remove the weapon blindly. Right? When I say blindly, that means you should not remove in casualty. It should be removed only in OT theater, and that too in a layer-wise manner. As you continue to open, you will trace the track. Now, why you should not remove is, let's say a patient who's been stabbed, this knife goes and pricks into a blood vessel, it is sticking into the blood vessel. Now, as the knife enters the blood vessel, it is, as long as the knife is there, it is preventing the blood from leaking from this blood vessel. It is creating a tamponade effect. The minute I pull off the knife, what is going to happen? It will start pouring and patient will bleed to death. So hence, you should not remove it. Another reason is the knife that has gone into the abdomen. Imagine, let's say, when it was entering into the abdomen, there were no injuries, right? But when you draw the knife back, because you don't know, you're drawing it blindly, there could be a bowel loop which is sitting on top, or vessel that is sitting on top, or any other organ. As you draw through it, you can cut through those structures. hence aggravating the injury. So hence blindly you should never remove the weapon of stab. Now, if the patient is unstable, as we all know, there is no point for guessing. Take the patient immediately for exploratory laparotomy. Take the patient for exploratory laparotomy. Now, if the patient is stable, but the weapon is still in C2, take the patient for CCT abdomen. Take the patient for CCT abdomen, right? So you take the patient for CCT abdomen. You look the patient CCT abdomen. You will look for any associated injuries are present or not, right? So in the CCT abdomen, usually we can give, if they're talking about abdominal injuries, so you can give CCT abdomen plus minus rectal contrast. You can give plus minus rectal contrast, right? So on a CCT abdomen, the first one you're going to look for any hollow viscous perforation. Is there any evidence of hollow viscous perforation? If there is an evidence of hollow viscous perforation, let's say if there is an evidence of hollow viscous perforation, take the patient immediately for exploratory laparotomy. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy, right? So if there is any hollow viscous perforation, okay? Now, on the other hand, if there is any feature suggestive of peritonitis, right? Okay, we'll keep it, I don't want to overcook this, we'll keep it simple. GSR, yes, what's the question, beta? I just did not see the chat box. Okay. Hi, good evening, guys. Okay. GSR BMC, what is the question? If you're still there, what's the question? You can post the question right across here. Okay? So this is a hollow viscous perforation. You will go ahead with exploratory laparotomy. Okay? Now, on the other hand, the weapon of C2 is not, or stab is not in C2. The protocol remains the same. You will see whether the patient is stable or unstable. So we'll have the same protocol here, whether the patient is unstable or whether the patient is stable. If the patient is unstable, directly take the patient for exploratory laparotomy, nothing spectacular about it. Now, if the patient is stable, I need to know that what is the status of the organ injury. Here we will do CCT abdomen. Here we will perform a CCT abdomen. Now, in the CCT abdomen, you are looking for any associated organ injury, right? You are looking for any associated organ injury. You see if the organ injury is present or it is absent. If the organ injury is present, take the patient for exploratory laparotomy. Organ injury is present, take the patient for exploratory. Take the patient for exploratory laparotomy. Okay? Right? Okay, thank you guys. Okay, from AIMS Bhubaneswar, welcome. So, if the patient's CCT abdomen, there is no organ injury or there is organ, if there is organ injury, you can go with exploratory laparotomy. If there is no organ injury, now this is where I will suggest the patient or take the patient for wound exploration. So, take the patient for wound exploration. And in wound exploration, I will see or I will assess something called as peritoneal breach. I'll do something or assess something called as the peritoneal breach. Now, peritoneal breach cannot be assessed. Peritoneal breach cannot be assessed on any cross-sectional image. It has to be examined physically. So here in a peritoneal breach, I can have two contexts. Where the peritoneal breach is present or it is absent. Hemodynamically stable patient, CCT abdomen has no evidence of any organ injury. On examination, there is no peritoneal breach. Such patients, you will go with wound closure. you'll go ahead with wound closure. On the other hand, if there is a peritoneal breach present, take the patient for exploratory. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Okay? So this is what you're going to look across here in the management of penetrating abdominal injuries. In the management of penetrating abdominal injuries. I know initially it looks a little bit of confusing because where to do a laparotomy, where to do a serial examination, where to do a wound exploration, all these are there, but this is the framework of your abdominal trauma. So even if you're working in a casualty, even if you're working in an emergency, if a patient comes to you with blunt trauma abdomen and penetrating trauma abdomen, these are universal protocols. You cannot afford to miss on it. If a patient in a blunt trauma abdomen comes to you in the casualty, the first thing you'll do is take an ultrasound probe and look for the assessment, which is called as FAST. Now we do an E-FAST where you'd look for thorax also, but in general FAST you'll look for perihepatic, pericardial, perisplenic, pelvic to look for collections. Earlier we used to have something called as DPL also. Currently also, if the FAST is negative, patient is hemodynamically stable, but you still suspect an abdominal organ injury, it is not conclusive on CT also, you can still go ahead with DPL, but again it's an invasive procedure. Forget about that. Let's say patient comes to you with blunt trauma abdomen, you did an ultrasound or a FAST assessment, it is FAST is positive. FAST positive, stable, unstable. Every unstable patient will be shown the door towards the OT. The patient will go for exploratory laparotomy. If the patient is FAST positive, hemodynamically unstable OT, that is exploratory laparotomy. Fast positive, hemodynamically stable, get the patient for CT and then do an assessment. In the CT, what are you looking for? You're looking for hollow viscous perforation. In a hollow viscous perforation, take the patient for exploratory laparotomy. If it is no hollow viscous perforation, you will assess for solid organ injury. If there is presence of solid organ injury, you will go with grade wise management, but before that, you look for any assessment or any presence of pseudoaneurysm or contrast blast. That pseudoaneurysm or contrast blast must be addressed with angioembolization. If it works, it works. If not, then you have to go according to the grade wise management. On the other hand, if there are no contrast blast, no pseudoaneurysm, nothing, then you can manage the other injuries as well. On the other hand, you have fast negative, hemodynamically unstable patient. Now, when we say hemodynamically unstable, there are features which are suggestive of peritonitis or status of shock. In those patients, you will take the patient for exploratory laparotomy. Fast negative, hemodynamically stable, do nothing, keep the patient for observation and then discharge after 24 hours. And this is what we do as a protocol of blunt trauma abdomen. In a penetrating trauma abdomen, the first thing you're going to ask whether it is a gunshot wound or it is a stab wound. All gunshot wounds must be explored because they are high velocity injuries, they're deeper injuries, they cause multiple visceral injuries. So always go with exploratory laparotomy. On the other hand, if there's a stab wound, you will see weapon of stab, is it in the body or not. If it is in situ, never remove it blindly. It must be removed during the surgery, and that too not suddenly with the incision. Layer by layer you will open up. In fact, as long as the weapon of stab is available in the body, it allows you to trace the path of that particular weapon to know what are the possible sites of organ injury. So hence should not be removed. Now you'll see stable, unstable, unstable laparotomy. Stable, you'll do a CCT abdomen, look for hollow viscous perforation. If present, take for exploratory laparotomy. If not, assess the other organ injuries as well. Patient hemodynamically stable, right? There is no weapon of stab in situ. What will you do? You'll do a CCT abdomen. Look for organ injury. Present, you go to exploratory laparotomy. If there's no organ injury, you will going to go for wound exploration to look for peritoneal breach. If the peritoneum is breach, you'll take the patient for exploratory laparotomy. If the peritoneum is intact, if it is not breached, you are going to go for wound closure. Right? This is the basic frame for abdominal trauma. See, abdominal trauma's lectures are going to be quite extensive. We'll go with each organ specific status. How do you assess it? How do you manage it? It'll be in your upcoming series. That is tomorrow. I'll talk about organ specific injuries in the abdominal trauma. Right? If you have any questions, feel free to ask here. And you know where to follow. If you have any questions, any queries, all that you have to reach out is here. It is the surgery guy. Now this is the Instagram ID, this is the Telegram ID. You can search it by my name also. It is Dr. Sandeep Seeram Reddy. So this is in terms of the initial introduction of abdominal trauma, right? So far, any questions? Quick feedback? कोई सवाल, कोई शक? Anything that you want to ask? Any questions? Quick feedback? Hi Liaquat. Okay, just saw your message. ठीक है. Right. If you have no questions, no queries, thank you so much for joining. See you tomorrow with organ specific injuries in the abdomen. Until then, keep revising, keep reading, and keep posting questions. Any queries, just make sure you be more intrigued, get into that, dig in, send all the queries. We'll try to answer them. With that, thank you so much. Good night. I'll see you tomorrow at same time, 9 o'clock. Bye bye. Chinnaswamy, good evening. Chinnaswamy, any questions? Chinmay Swami, sorry. No questions? No questions, no questions. All right. Okay. Thank you guys. Bye bye.